And thanks again for this honor to be here, and Jonah for those kind words of introduction. You can go to the next slide. My disclosures are listed here, and if you can go one further slide. So to start out with, the biology of cannabis is fascinating and I think often very misunderstood. There are two main species, sativa, which was first identified by humans at least 10,000 years ago in China, and indica, which comes from the Indian subcontinent and was described more like 3,000 years ago. Those two species, if you ever go to a dispensary in California or Colorado, things will be labeled sativa or indica, but that's essentially like saying someone's a purebred Eastern European when they may be 3 generations intermixed with other people from around the world. These species have been highly interbred, so they're not pure anymore. The other thing it's important to recognize, there are many cannabinoids, more than 500 cannabinoids, terpenes, and flavonoids, which give cannabis its smell. But the two that I'll be focusing on here are CBD, which is now fairly famous. It is not psychoactive. It works on probably 15 or 20 different receptors and neurotransmitter systems in the brain. The one we think is most relevant for epilepsy is the GPR55 receptor, but it also works on the TRPV receptors, which are important for pain and some affective behavior. The serotonin receptors, which may be very important in its anti-anxiety effects, and it has more than 15 anti-inflammatory effects, so it's quite an interesting compound. It is, as I said, not psychoactive. THC is the more famous of the two over time, and it is the psychoactive one. It is the one that gives the high of consuming cannabis, whether inhaled or orally, and it specifically stimulates a receptor that's well known, the CB1 receptor in the brain, and the CB2 receptor, which is more widely distributed outside of the brain and primarily involved with immune function. Next slide. So this slide summarizes, and excuse the busyness, but within some of these 8 broad mechanisms, you can see number 3, that there are about 10 different pro-inflammatory cytokines that CBD will downregulate. So CBD is actually quite a remarkable anti-inflammatory compound, which may contribute to its effect both in epilepsy, in autism, as well as other disorders such as inflammatory bowel syndrome and many autoimmune disorders as well. Next slide. This is a table, histogram, that summarizes many, more than 35 preclinical models looking at various cannabinoids to treat epilepsy. So I'll focus your attention to the 2 bars on the far right. The one right before the end is the delta-9 THC. That's the active ingredient in cannabis that makes people psychoactive and enjoy it. This has largely anticonvulsant properties, as you see from the green portion of the bar, which is about 65%. There's a tiny bit where it aggravates seizures in animal models, some where it has mixed effects, and then about 30% of the time, THC does not have any effect on seizure threshold in these animals. By contrast, both CBD and a related compound that I will mention because there's an autism trial going on, CBDV, are almost all about 75–80% anticonvulsant, and the remainder is no significant effect, but they have no proconvulsant or mixed effects. So in a nice way, CBD and CBDV are a bit cleaner for epilepsy concerns than is THC. Next slide. So this is some work that was done by several different groups, and essentially it's true for so many of the compounds we've learned about, the opiates, the benzodiazepines, THC, that they work on endogenous receptors. It's not that plants or some other organism makes a compound and it magically works in our brain. It works in our brain because we have compounds that we make ourselves that mimic the effects of these compounds. It's true for THC and it's true for CBD. So there's a lipid in our brain called LPI. I won't give you the long name, but trust me, I can give it to you, anyone who's interested. And it goes on the top side to excitatory neurons and it further stimulates them. And this was identified by Salantev's group about a decade ago. And more recently, in work that we hope will be published soon, Evan Rosenberg at NYU, Dick Chen, who heads the Neuroscience Institute, myself, and several others, showed that LPI also leads to a decrease in inhibition. So LPI is an absolute nightmare for disorders in which we think there's too much excitation and too little inhibition. And this includes epilepsy, autism, and schizophrenia, where this E to I ratio is off and there's too much excitation and too little inhibition. CBD remarkably breaks this cycle. CBD blocks this GPR55 receptor, which is where LPI normally stimulates, and it leads to a decrease in excitation, and it prevents the decrease in inhibition. What's even worse about this is that when LPI binds to GPR55, it stimulates excitation, it shuts off inhibition, that leads to seizures, and seizures themselves lead to elevated GPR55 receptors, creating what is essentially a positive feedback cycle and can make epilepsy and seizures both worse. Next slide. So this slide highlights some of the pharmacology of CBD, and I think this is an important slide for anyone who has ever considered using CBD themselves or given it to their child or family member. CBD, like all cannabinoids, is highly fat soluble. It does not do well in water. It would separate, and its absorption overall when taken orally is quite poor. Overall, with a standard empty stomach or standard carbohydrate meal that most Americans consume, about 4 to 6% of CBD is actually absorbed, which is terrible. Most drugs that you take, like acetaminophen, ibuprofen, they're 90 to 99% absorbed through the GI tract. If you take CBD with a high-fat meal, could be an avocado, could be olive oil, whatever, the absorption can go up to 20% or perhaps a little bit more. CBD is a drug. I know that for many people it comes from a plant, so it seems like it's natural, but it really is a drug, and it is metabolized in the liver, and that can give rise to some issues. In the table below, I'll just point out a couple of things. This is a large dose of CBD given to normal volunteers, 1,500 milligrams. But if you look at the numbers in parentheses, I'm not worried so much about the Cmax and the area under the curve, but if you look at the number to the right, 87.9 and 78.2, that is the coefficient of variability. And it speaks to the fact that these are normal controls under identical conditions. There's so much variation in how much is absorbed between people and probably within the same person between doses. Next slide. So how do we learn about any drug, any treatment? We need blinded trials. And again, I think it's really hard for lay people in times to understand this, and doctors too. We feel like if we've seen something, we believe it, it's got to be true. But doctors, patients, we're all wrong most of the time. So the way to limit bias is to make neither the clinician nor the patient or the family member have any idea whether they're getting the active compound or a placebo, and randomly assign patients so you can get rid of other things like socioeconomic status or geographic location or co-medications, because if they're randomly assigned and you have enough numbers, this should reduce all of those confounding variables. And it's also the only way to figure out if a drug causes side effects, because placebos can have 80% side effects in some studies. And so it becomes really important as well. Next slide. So this, I'm just going to go through quickly. This is from our New England Journal study of Dravet syndrome with cannabidiol. And what you can see here is what are large doses, 20 milligrams per kilogram per day for the average adult who's 60 kilograms, or about 130 pounds, lighter than me. That would be 1,200 milligrams per day. And this looks at the phase 3 trials, and you can see there was quite a statistically significant difference, less than 0.01, in the reduction in seizures between the CBD and the placebo group. Next slide. And this looks at 2 different studies in Lennox-Gastaut syndrome. One was by Elizabeth Thiel, who Dr. Jesty just mentioned, and that was the one on the left, and again showed a very significant difference. And the one on the right is one I was involved with, where we first compared 2 doses, 10 and 20 milligrams per kilogram per day. And the take home is that both doses worked. It turns out the 10 milligram per kilogram day actually had significantly fewer side effects. Not surprisingly, it was half the dose, but the efficacy was only about 4% less. So this is the recommended dose that we currently have. Next slide. As I said, CBD is a drug. It comes from a plant, but if you take 100 pounds of coca leaves and you get it down to 10 grams of a white powder, that's cocaine. And although it is natural as anything on the planet, it's very highly processed and it's a drug. And the same is true of CBD. CBD is thankfully much, much safer than compounds like that, but it still is a drug. So we see more somnolence, we see more GI problems, diarrhea, decreased appetite, weight loss, elevation in the liver function tests, there were more infections, and there were drug interactions. And the rate of withdrawal was about 7 to 8-fold higher on patients getting CBD. And the two most common reasons were elevated liver function tests and tiredness or somnolence. Next slide. So there are other forms that have been tried in other trials, both CBD and CBDV, and in focal epilepsy to date, the treatments have not really done better than placebo. It could have been a dosing, could have been other issues with these two studies, but two studies to date have really failed to show that CBD works outside of Dravet, Lennox-Gastaut, and more recently, data in tuberous sclerosis complex. Next slide. So let's turn to autism now. And the first study that was done was one by Zynerba using a transdermal synthetic CBD. It was open label, meaning there was no blinding. The patients and families knew what they were getting, and the doctor knew what was being given. And they looked at several measures of anxiety and behavior, and it actually did quite well. Overall, the reduction in negative behaviors in this group, which was Fragile X primarily, was quite positive. There were adverse effects, but most were mild and none were serious. Next slide. This is another trial that was reported, I believe, from an Israeli group looking at a common ratio of, it should actually be 20 parts CBD to 1 part THC, about 53, mostly children, but some young adults treated for 1 month to up to almost 2 years. And there were significant reductions in self-injury, in hyperactivity, in sleep problems, and in anxiety. Although do note that, for example, sleep problems, 45% reported more problems. Hyperactivity got worse in a few percent. Self-injuries, behaviors got worse in about 9%. So again, and this is the expected noise in any system, because some of these individuals are just going to have spontaneous worsenings in their behavior, but there may also be real negative impact. Keep in mind, individuals in the general population fall out into a bell curve, how people tolerate meds and how they react to them. I believe in the autistic population, that bell curve is even spread out wider with more intersubject variability. The side effects in the study were very similar to those seen with CBD alone, somnolence and decreased appetite. Next slide. This is yet another study done from Israel, from Orrin's group, with a CBD-rich cannabis, and they looked at the global clinical impression of change. And 61% of these children with autism, and we're focusing here on behavior, were much improved according to the parental raters. Among the side effects, problems with sleep, irritability, decreased appetite, and rarely psychosis in a child who received a high THC compound. Because in this study, they started with primarily CBD, but if that wasn't effective, they gradually increased the THC content. And there's another study that reported on an even larger group, 188 patients with autism, treated with a primarily CBD, but a 1:20 ratio with THC. And again, improvement was significant here, 30%, moderate in 54%, slight 6%, no change 9%, and none were worse. And similar side effects, restlessness was a bit more common in this study. Next slide. So there are some ongoing trials in autism. I'm aware of 2. There probably are more. One is led by Javier Castellanos at NYU, and that uses CBD from GW Pharma. And there's another one looking at CBDV, also from GW Pharma, now acquired by Jazz Pharmaceuticals. And this is a collaboration between Eric Hollander and myself. Eric is the PI at Montefiore, and NYU is the other site in the study. These studies are both recruiting now, and if anyone has interest, they could reach out to me or directly to Dr. Castellanos or Dr. Hollander if you're interested. But these are trials that we await the results from. The CBDV trial is a blinded trial, and I think we need to get more rigorous data I think, it's intriguing, the Israeli data with THC with CBD. Keep in mind, one of CBD's effects is to actually block some of the effectiveness of THC. So at the 20-to-1 ratio, the effect of THC is probably quite small because CBD actually does have some negative impact on the CB1 receptor, whereas THC is a pure stimulant of that receptor. Next slide. And then finally, I'm not going to spend much time here, but there's an emerging large science that CBD has anti-anxiety properties. The current anti-anxiety drugs all have some side effects, especially the serotonin agents. Benzodiazepines work on the GABA receptor. The benzodiazepines can be addictive. I just saw a patient today, 20-year-old in college, who used Xanax to go to sleep for 2 weeks, stopped it for 2 days, and then had his first tonic-clonic seizure. So the withdrawal from these can be bad, and they contribute to many overdoses in the United States. Obviously not a concern so much in the autism population, but it very much is in the overall population. CBD has an anti-anxiety effect, which seems to be modulated by its effect on the serotonin receptors. Next slide. And you can go forward with this one. I think it's several parts. This is a chronic stress model in mice, and you can just see, again, CBD here significantly increases the open. When mice are put out, they're much more social in this chronic stress model when they've been given CBD, so it reduces anxiety. And the next slide. And here's a public speaking slide of just normal adults who have some social anxiety. And you can see the CBD arm in blue significantly reduced the anxiety, I should say in red, reduced the anxiety compared to placebo. So again, there's good evidence from animals and humans that CBD is anti-anxiety, and its mechanism of action on the serotonin receptors would lead us to predict this. Next slide. And then finally, just a couple minutes, we are now living in an unusual place. I think well over 30 states have medical marijuana that is available. And so if people get, like in New Jersey, New York, where I practice, I can write a prescription, I can say high CBD, but they can go into a dispensary and someone with a high school education could say, no, I'm kind of an expert on epilepsy and autism. I think you should be on the high THC. And so literally there's no rigorous data, no rigorous safety data, no rigorous efficacy data, and literally people in dispensaries without much medical knowledge at all may be making strong, and this has happened to many of my patients. And then of course there's the internet, where there are hundreds of thousands of experts happy to give advice on dosing of CBD and THC for autism or any other disorder. And I have no doubt that they're all well-meaning people, but all I can say is, having treated hundreds of people with autism and probably 300 or 400 people with epilepsy with CBD and THC combinations, I would say my knowledge is quite limited as far as what I truly know outside of the epilepsy trials. Next slide. And so some of the challenges with medical cannabis are that religion is belief without evidence and science is doubt despite near certainty. And as I said, I think in the dispensary community, in the lay community, there's often a conviction that we have the answer. It's like Trump supporters and Biden supporters. On the extreme side, they're 100% sure they're right, and yet they disagree completely. And I think it's not terribly dissimilar here. It's a little bit like politics. And I think ultimately we need science. And there are many human biases that are now well documented in many popular lay books by Kahneman and others. And there are so many biases that we have, and we tend to support our own biases when we read something, even if the data actually contradicts what our bias is. So keep in mind, no matter how smart you are, how high your IQ, whether it's Dr. Jesty or myself, we are all biased, and we just have to keep checking ourselves. And that's why I said science is when you're 99% certain, you still have doubt. Next slide. And so just to conclude, CBD and THC both have nicely demonstrated anti-seizure effects in animals. CBD has been proven to be effective in treating seizures in 3 rare epilepsy types. There's no efficacy to date of CBD or CBV for focal epilepsy. We need data for other epilepsies. We need safety data on the efficacy of THC. We really have very little, especially in children. And in autism, we have a lot of supportive open label data. but we absolutely need randomized controlled data to have a good sense of where to go. It doesn't mean it shouldn't be used. And like I said, I've treated hundreds of people with autism with CBD and with THC, but let the buyer beware. We need to be humble as both the physician side and the parent or patient side about what we're seeing, because when you go in believing, you almost always confirm what you came in believing, regardless of what the truth is. Thank you so much again, and I'll open it up for questions.
Thank you, Dr. Devinsky. I know that this can be a controversial topic. It shouldn't be, but it can. We have gotten a couple questions. One is about tolerance. So do you see any changes in efficacy of CBD with continued use?
I think there is some tolerance. I think in my experience, almost every drug has some tolerance. The nervous system and the brain are exquisitely made to become tolerant. Anything we're exposed to over and over, we get used to it. It has less of an initial start. When we start a meal, it tastes better when we're hungry than at the end of the meal. And that's why phrases like good to the last drop comes in, although I'm not sure it's true about that product. But essentially, we adapt to everything. And I think in part there is some tolerance to CBD. It's not a lot, not nearly as much as the benzodiazepine, but there's some.
That's a good point. We got another question about the potential sedative effects of CBD. I know you did show one graph that compared sedation versus anti-anxiety effects, but do you think some of the effects on seizures or even some of the symptoms of autism could be because of sedation, or what is your response?
It's an intriguing question. Without a doubt, somnolence, tiredness is a side effect of CBD. Keep in mind, in the trials I was discussing that I was involved with, we used quite high doses. So we used, for the average 60 kilogram, 130 pound adult, it would have been 600 to 1200 milligrams per day. Keep in mind, if you buy a Recess soda, which is sold in New York City and has CBD, it has 10 milligrams of CBD, which is a placebo dose in my view, because you probably absorb, if you're lucky, about half a milligram, and would be like taking 1/100th of an Advil and hoping your headache goes away. So I think, that's one thing. It depends on the dose, very much what side effects you'll see. I don't think the anti-seizure properties are just due to sedation, because there are many compounds like diphenhydramine, better known as Benadryl, or present in a lot of the sleep medications, that is quite sedating, but it also makes seizures more likely to occur. So just pure sedation tends not to control seizures. Certainly a lot of the drugs that treat seizures are central nervous system depressants like Valium or Klonopin or phenobarbital, but there are drugs that are sedating that make seizures worse.
And I'm glad and thankful that you mentioned the wild, wild west of not just dispensaries, but you can buy CBD anywhere now. You can buy CBD at our local, around the corner liquor store. You can buy it at Wegmans grocery store. Do you have anything that you want to particularly say about not necessarily the dangers, but the expectations of taking stuff that you're getting at a gas station?
Yeah, I think, I wish I knew Latin better, but, there's the Latin phrase, let the buyer beware. And so, when CBD first started to become popularly marketed on the internet and people were buying it for themselves or their pets, the FDA looked at, I think it was 14 products, and 12 of them, had less than 1/5 the amount of advertised CBD. So probably the biggest problem when you buy CBD at a gas station or at a bodega or wherever is that you're probably getting very little CBD. And if you're getting, that little, it's really probably doing nothing. And I just wouldn't waste my money on it.